Hey Jay, how you doing?
Hey Jim, good afternoon.
Yeah.
Looks like we're live, and we've got a pretty nice crowd here today.
Okay, great. Looking forward to talking about this some a little bit.
Well, thanks. Let me let me go ahead and get started with a little bit of background. I'm going to introduce myself, and then maybe Jim, you could do a bit, and we'll start talking about the session.
Sure.
Um, Welcome everyone. My name is Jay Fisher. I'm one of the partners in the firm that's organized today's session, C3 Partners. We do Meaningful Use Monitor, which is a compliance database tool for around meaningful use. We've worked with Jim off and on for a number of years, and in the last several months, both Jim and I have had the opportunities to work with a lot of clients who've been through audits, both on the hospital and on the physician side. And Jim's had the unique experience of carrying the very first hospital through a CMS audit. Jim, you want to just take a minute and talk about yourself, and then
Sure.
I'll jump into a couple of preparatory remarks
Uh,
on the presentation.
be glad to, Jay. Glad to be here today. Let me correct one thing. You said I was helped take the first hospital through an audit, and I'm sure I wasn't the first to go through an audit, but we were the first to go through an appeal of a failed audit, which is maybe even scarier turf to be on. And glad for everybody that we were successful in that. My background is in healthcare, but for the last 6 or 7 years, I've been involved with over 200 EHRs on their certification processes, and then of course the meaningful use work, and very involved with both eligible professional and eligible hospital audits and appeals of those incentive audits now.
Okay, and that's what we'll get a chance to talk about now. Let me give you a tiny bit of background here in terms of getting up to the point of appeal. As I said, in the last few months, I've worked with a small number of hospitals and physicians who've had some challenges with audits, and I think that we can see a couple of patterns. When we see people who have troubles with a meaningful use audit, I see those troubles falling into a couple of different categories. There were initially some providers who maybe stretched the truth a bit in terms of their attestation, and in some cases we can help those, in a lot of cases we can't. I think probably the second piece is really a lack of an understanding of the details around all the meaningful use measure, and I'm sure Jim will have a couple thoughts around that as well. Probably the most common issue that we see, though, is providers actually compliant, fulfilled all the requirements, did everything they need, but when it came time to put together the documentation, they didn't have all the documentation that was in place, and they weren't able to respond to the auditor when the auditor asked for that. And then the last category is, the auditor just makes a mistake in understanding in what happens. Now,
I was gonna ask you about that one, Jay. When I saw you have the list on there, auditor error. Are you talking about maybe there's been some miscommunication, something along those lines?
I think it's the case where we saw this. The auditor had
Sure.
a misunderstanding of what the provider was documenting and what they were showing in their documentation.
Mm-hmm.
The documentation maybe wasn't quite as tight and as comprehensive and as clear as it should be.
Certainly.
And so the auditor maybe didn't take the time to understand everything that was in front of them.
Well, and that's a really great point. And let me bring up this aspect of it. As we know, there's well over 300 2011 edition certified complete EHRs. And so each one of these in their own ways is generating these meaningful use documents and reporting information sheets. And so they all look different. And so these auditors don't know these EHRs, and they're just, there's such a variance about the documentation that comes out of these systems that I think that's a very good point you bring up, that just being able to understand what you're looking at, especially in the early days of audits, I'm sure that was a big problem.
Yeah, and we'll see as the audit program expands what we come up with. But
Sure.
as we get to Jim's point here, I think that if we've got a situation with a provider that's category 1, they've stretched the truth a little bit. Boy, pretty hard to appeal that one.
Jay, I like to call that a knowledge gap.
that
Okay.
will work.
Okay.
Or or maybe being, a little overly aggressive about attesting. Right?
Exactly. Yep. Sure.
But I think when we get to these, categories 2, 3, and 4, especially categories 3 and 4, I think that we're
Yes.
probably in a case where we're going to have, in many cases, a good chance to actually appeal an auditor that turns you down, much higher than the first couple.
I would agree.
So now let me take a look at another another thought here, and just to provide a little bit of context around where Jim's conversation is going to go today, and then I'm just gonna turn things over to Jim here. When we look at the process of going through meaningful use and attesting to meaningful use, where the context of today's discussion is we assume that a provider has attested. Now, in our nomenclature, we have we look at the different kinds of layers of defense that you can have. You can do some things to make sure that your attestation is clean and accurate and isn't raising any red flags, right? Kind of a second layer of defense is that you can make sure that all of your documentation is lined up, have your meaningful use coordinator do the best job, have a third party come in and do a mock audit to make sure your documentation is good and it says what you think it says to an outsider. And then we start getting a little closer, the audit actually happens, right? What's the work that we can do to respond to Figliozzi when they request documents and when they have follow-up requests on things that they saw that didn't go well? Right, and at the end of that point, Figliozzi is going to either say you passed or you failed. Let's assume for a minute that they said that you failed. Now, what do? Are you done? Do you have to hand your money in, or are you completely toast? And that's where we're going to get into the experience that Jim has had here with actually taking that failed audit and turning it around into, turning that failed audit around into an ability to get your money back again. So here's some of the thoughts that Jim asked me to put down on paper. And, Jim, if you could kind of talk through this stuff. Yeah, by the way, before you get started, I am kind of tracking questions. If you have questions as people go on, just log them in your go-to webinar question widget. And
that sounds fine, Jay. And I know we don't have a lot of time today, so hopefully we can follow up with some of those questions as they come in another time. Let me first say one of the things that you mentioned, Jay, was that possibly at the appeal level, you can win an appeal of a failed audit and get your money back, or be able to recoup the money that was recouped from you. If there is a possibility, and I have been successful with one hospital in which we moved so quickly on the appeal that we were able to have it reversed before the due date of the recoupment of the EHR incentive. So that doesn't always happen, but that is the potential of it. It's better to keep the money on the hospital provider side rather than having to try and get it back after you reverse things. Some best practices I want to mention. When in doubt, always appeal. There's no problem with the appeal process. If you receive notification of a failed audit, pretty quickly after that will come a recoupment letter telling you exactly how much money is going to be recouped, but also your appeal rights. So there's never a reason not to appeal. But this will be your last chance to be successful, and even a relatively small hospital, 20 or 25 bed hospital, to be audited for a 2011 incentive. That Medicare, for critical access small hospital, that Medicare HR incentive is over $1 million, not even talking about the Medicaid incentive. So this is the last chance to be successful, and if you're not able to reverse that appeal, that money is going back. And for any size hospital, $1 million or more, certainly a large hospital, it'd be much more than that. That could be not only problematic, but catastrophic. So it really is the last chance to be successful. Since the audit was failed, obviously something was wrong. It is more like you've been through a process of providing clarification, documentation, explanation over a period of months for the auditors, and you have not met their expectations. So if that exact same level of documentation, explanation, and clarification is taken to the appeal level, I think you would probably not have much chance at all of reversing an appeal. There's got to be some new clarification, some new documentation, some reason brought up to be able to, at the appeal level, get a positive ruling. So many times I'm contacted by providers or hospitals who already failed an appeal. And at the appeal level, and actually what happens during appeal is there's certainly some paperwork that initiates the appeal, but the folks at the appeal level, they can request all your prior documentation from the auditors. And so that's going to be uploaded to them, and the appeal folks get a hold of that, and then they can take your new documentation and add it to what's already happened during the audit process. But if you fail on one or two modules, there's no need to go into a long, extensive explanation to the at the appeal level on what the auditors did right, what the auditors do wrong, how frustrating it was for you. You want to keep that as simple as you can. The appeal will be based on those particular modules, meaningful use modules and measures that you failed. So you want to be able to just keep it as simple as possible, tell the story backed up by clarification and guidance on those things that were failed. And don't overcomplicate this at all. It can be very, very complicated, but we want to keep it simple. Now, one thing I found about hospitals in particular, a lot of the audits and appeals that have come across my desk is at the hospital level, there really isn't a problem with the security risk analysis. Most hospitals are so large, they've got a security officer, they're doing HIPAA regulations, they've got that covered. Not so true for the eligible professionals. The vast majority of them may not have that proper documentation. But on the hospital level, one thing that I've seen especially is if attestation took place in 2011, an audit is taking place in 2013, and the people who are in charge of the audit and then the appeal for the hospital may be different people that were involved in attestation in 2011. So the strategy that was used for attestation, what was excluded, what options were taken, may not be clear. And so that can cause certainly a lot of confusion. One big area of confusion certainly is, again, for eligible hospitals, was that many of the denominators for the meaningful use measures could be either based on an observation services method or a all emergency department method. So there was some couple different options that would the basis of which would affect your meaningful use numbers. And to know what the strategy and theory was behind that is an important thing. You kind of mentioned some of the red flags, Jay, that providers could kind of get them in trouble, but there's also some problems sometimes with the technology. I recently had a hospital go through an audit. When they ran their original meaningful use measures, and a test in 2011, one of their measures, I believe it was problem list, was which needed to be over 80%. I think they were 86%. When they were audited, they needed to rerun that report. They reran it again for that same period of time, and it was 76%. So when they originally tested, their data said they passed. When they ran it again during audit, it didn't pass. We investigated that, and it turned out that back in 2011, and I worked with many of these certified EHRs, the vendors realized that there were some erroneous algorithms calculating some of their measures, capturing some of their measures. And so when they would discover that, they would upgrade their software, and then if you run that same report again, you may get a different number. So there was.
Jim, let me ask you on that. One of the bits of advice that we always give to our clients is that when you're preparing your attestation, don't rely on the ability of your EHR to be able to generate those reports a year or two or three from now. We're always telling our people create a PDF or a paper copy. Save it off in an electronic folder or a binder. I mean,
You know
is,
that,
you know,
yeah.
on the appeal, are the auditors, are they trying to ask for things out of, current system, or are they asking for, historical documentation out of that period that failed?
Well, what they're asking for initially is well, they're going to request from the auditors all the prior documentation that you provided that you
Hmm.
used in support of that initial attestation. So that's what they're looking at. At the appeal level, though, they do show more willingness to look at other aspects and explanations and clarifications around some of the details that I just mentioned. You can provide additional documentation. Uh, on the appeal forms, and at my website, emradvocate.com, I've got links to the appeal forms for providers as well as hospitals. And one of the questions they ask there is, uh, could you meet meaningful use for another 90-day period, or another reportable period,
I've heard
and
that
you could,
question too.
right, and you can report that. So that shows the potential for some flexibility there. Um, to me, though, if whether it's an audit or it's an appeal, I think it's incredibly important to have one person, whether it's a small practice or a large hospital system, who owns the process. Somebody has got to be on top of this. If there's too many cooks in the kitchen, that's always a risk. That
Yeah.
never helps.
Yeah.
There's just too much at stake. Very important to establish communication with the auditor or whoever is your appeal contact, so you very clearly understand what they want. The worst possible outcome would be to not really know what's going on with the process, and before you know it, you've got a failed audit or a failed appeal, when possibly you could have made arguments or provide documentation. So it's very important at this level
Jim,
to, yeah,
can you pause a second? I'm tracking a whole
sure,
bunch of questions that have come in, and
sure.
most of them can hold off until we get a little further. Although somebody did just ask, can you share your website again, your URL again?
Sure. It is EMR Advocate, EMRADVOCATE.com, like electronic medical record advocate, EMRadvocate.com. And there's a contact there also, Jim Tate, JIMTATE at EMR Advocate. And be glad to have an initial call with anybody to see if, what position they're in. Some folks you just can't help. If somebody just absolutely not only does not have documentation, but clearly didn't do some things that are core measures and are required, not a lot of help that can
Hmm.
be done. But uh, you want to make every possible effort. So I would always appeal. I would always appeal. But again, if you fail an audit, you've got to have a different approach at that appeal level. Something. You can't just hope to get lucky during the appeal level.
Jim, when you ran
Yeah.
your appeal, when
Mhm.
when you've done, this appeal or any other appeals, is this all work that can be done remotely, or have you had to
It
get in person with anybody?
right. It has all been done remotely. Never had to go. I've been on site to some providers and some hospitals just to examine some potential data. But with both auditors and the folks at the appeal level, everything's been desktop. Now, and I've talked with the auditors and those that are handling the appeal, and I find them extremely approachable, and they don't get any benefit of anybody failing audit or appeal. It's not that like the rack audits where auditors receive money,
Right.
percentage of the. So it's not like that at all. So if it's a bad day for you, it's a bad day for them. Certainly a worse day for you. But I have found them very open to arrange phone conversations and be open to explanations. So
And I did
that's
have
good.
one other question that seems to fit at this point too. Is there a time limit around? It looks like two parts to this question.
Hmm.
Is there a time limit around how long you have to initiate your appeal? And once initiated, is there is there a time box around how long you have to complete the appeal?
I'll have to go back and look at the actual appeal documents because I always, folks I'm working with, we generate that appeal the second we know we have a failed determination.
Sure.
Because we're trying to get to the appeal level and have the decision reversed before the deadline of when that money's due.
Mm-hmm.
So I have never looked at the other side, how long. There definitely is that when from what I've seen so far, and of course this is subject to change based on regulations, but when there is on the audit level a failed determination, and then 3 to 4 weeks later a letter comes in saying we're recouping X amount of money, and usually it's the due date on that is 30 days out, something like that, 30 days out. And 30 days after that, 10% penalty starts being added, and after 60 days, it's turned over to the Treasury Department. So I don't want to be involved with the Treasury Department or trying to ask for money back after. I mean, my goal is to do it as quickly and as efficiently as possible.
Yeah, I've noticed that in the couple of auditors that we've seen that have, or the audits that have failed, there actually is a notice right in the failure letter describing what you can
That's
do
correct.
to appeal.
Yep.
So it's not hard to figure out what your next steps are.
That's exactly right. There sure is. And as far as the timeline, I know the initial goal for an audit was from notification of an audit to when it's finished. I've heard that they want to get these files, once they open up, closed within about a 3-month period, about 90 days. But I've seen documentation which they stretch out longer than that, which is a shame, but they can drag out longer. People don't return documentation, things like that. I don't know. From what I've seen, there's certainly no need for an appeal to drag out that long once one gets going, because you provide you fill out the appeal form that asks for additional information, clarification. They have the auditors upload prior documentation. In the recent case where we had a hospital appeal, then we had a phone call with somebody at the appeal level to gather some more information. We had a conference call. We explained everything, and it was about a week and a half or 2 weeks later, we received the Valentine that said, just go back to taking care of patients. It's all good. So, yeah.
So have you had a case with an appeal where you've been able to resolve things strictly verbally, or is there always documentation involved?
Always documentation.
I would expect so, yeah.
Because I always feel that we have to, I don't think that, I don't want to put the appeal level to just say, I don't want to say to them, the auditors are wrong, you need to rule them my way. I want to give them reasons and new reasons that show that we're now meeting their expectations. So I always, yeah, it's different documentation, a different view of things, a different way to run reports, something.
I see another interesting question here, is that in the appeal, is the original individual from Figliozzi involved?
No, that's a great question. Once the auditors have made their final determination and you make your appeal, it goes to a total group, a different group altogether.
Mm-hmm.
Yeah, it sure does. I don't know what will be the ongoing process, but I know that at the appeal level, again, conference calls, able to provide new clarification, explanation, and then from what I've seen so far, again, subject to change, it's not just one person in the room checking yes or no. They actually discuss it with a group of people, because there needs to be consistency. As with audit process, the appeal process needs to be consistent across the board. Whether we, Jay, we knew ever since early 2009 when the high tech regulations were passed, audits, then appeals were going to come, and they're here now, and we'll be seeing them for at least 5 years or so out there. Um, One thing, of course, the audits are done for Medicare and duly eligible Medicare and Medicaid, which is mainly hospitals, by Figliosi and Company. And if it's a pure Medicaid incentive, each state's doing that. And so each state, if it's a pure Medicaid incentive audit that's failed, is going to handle the appeal. So everything we've talked about is certainly for the Medicare incentives and
Medicare
the duly
centric.
right and the duly eligible, which almost most hospitals are.
Yeah, and
So,
that's what we're seeing on the audit side as well. I
yeah.
mean, certainly the Medicare and duly eligible audit is far more complex, covers a lot more topics and issues.
Right, it certainly does. And um, the appeal is the court of last resort. There's nothing beyond an appeal. That's the Supreme Court as far as all this goes. So the fact that yeah.
So you think that so let's say the appeal process works, you've filed some documentation with the appeal, you've had some conversations. Is the person with whom you appeal, do they tend to interact with you in conversation to ask, what you meant by this, questions? Do you have any further elaboration, or do they take what you give and last chance?
I think there is certainly room for conversation. It's not the auditors or the those at the appeal level to help you come up with new documentation or reasons or clarification. I think they do a really good job of telling you exactly what their expectations are, but they're certainly not. They may, but certainly not within their scope to suggest strategies or alternatives to you.
Sure.
Sure. Yeah.
We're running pretty close to the end here, and I've got a couple
Sure.
questions that might
Please.
require a good elaborative answer. Let me read one of these. Karen asked about what initial items are sent in that first contact from Figliosi, and would you be willing to share that to have an understanding?
Sure. That initial letter, the audit engagement letter, they are asking for all documentation that was used during attestation. So that means they want the meaningful use documents that were printed out of your certified EHR, enumerators and nominators. They want your security risk assessment, which has nothing to do with your EHR vendor, but it's something that a provider has to have done on their own. They want anything that comes out of the EHR is going to document the percentage-based measures, plus that security risk analysis. But then again, the non-percentage-based measures that you had clinical decision support enabled the entire time, that you had the drug formulary enabled the entire time. Those kind of things, those can be a little bit more difficult to generate. And so
simple problem, little more tricky proof.
Right, and so your proof may have to come to the vendor, from your vendor. So I'd contact your vendor, and I'm sure every vendor now has had people who've gone through the audit process, and they should be able to provide you that additional documentation, which probably cannot easily come out of your EHR, but those non-percentage-based measures.
But you mentioned security risk analysis. I've got a couple of questions and comments.
Yeah, that's the tricky one
on that one.
For professionals. It really is.
I mean, basically, one of the comments here was maybe not very complimentary of CMS or Figliosi, but saying essentially they don't seem to know what they're looking for. And is there any sort of standard that you're aware of documentation that shows that you've completed one that seems to work?
Right. Well, I would Google if you want to know what won't work. CMS has a great document out, or probably ONC. If you Google myths of security risk analysis, there's like 10 myths. Such things as, if I'm using a certified EHR, that covers it. If I use a checklist, does that cover it? So they really put those to rest. But I think what what the auditors are looking for, from my experience, is that there has been a, comprehensive review of, well, first of all, let me say what this is all about is we're trying to protect electronic health information. So this security risk analysis is really a subset of HIPAA, but it's health information that is in an electronic form. So areas that have to do with workflows, with hardware, with software, that these things have been reviewed, identified whether they're a risk or not. If a risk is identified, like you have a computer server at your office and you don't do backups, or you don't have uninterruptible power supplies, that's a risk to health information. And so go ahead, Jack.
Let me pause you a little bit here, because we do have two other related questions to this.
Sure.
And one of them, I've had a couple people ask about, can we recommend any, risk assessments? And I think both Jim and I will be, we'll be responding after this, and between the two of us, we'll put something together on our website and on Jim's website, with a couple links to some that we know about. Certainly not a comprehensive list, but some that we know about that work.
Sure.
Reasonable?
Right.
Yep.
Yep, that sounds fine. And so they will see some type of reviews been done, some threats have been identified, and there's some kind of plan to mitigate those risks. It's just a living document. If you have a new practice that opens up, a new location, that should be part of it, and identified, things like that. So.
Okay, I'm chuckling at the somebody's looking for what's the number one here. We've been talking a lot about risk. What's the most commonly missing piece of information or documentation that results in a failed audit? I have a couple opinions. I'm sure you do.
Right. Well, for eligible professionals, doctors, clinics, it's security risk analysis, open and shut. That's probably the number one, because they don't have it. And they didn't understand that they really needed it. So for hospitals, I'll let you take that one, Jay. What do you think the number one failed is going to be for hospitals?
I think security risk analysis is on the list even
Okay.
for hospitals.
Sure.
The smaller, the critical access hospitals, maybe not those that have a big place.
Sure.
I've seen problem list. I hate to say it seems like an easy one, but I've seen.
I have too.
I've seen troubles with problem list because of and again, it's maybe not always lack of really being compliant, but lack of documentation around problem list.
That's right.
And then number two, the kind of the whole list of yes/no measures that Jim referred to earlier, where what was my drug allergy checking turned on, and there's an assumption that I can always prove that after the fact, and you can't. I mean,
Jay,
it's very hard to prove.
That's really true. I know we're almost out of time here, but many hospitals do not have one centric, comprehensive electronic health record system. It's parts self-developed, maybe from numerous vendors, plug and play, best of breed type strategy. And so if they're having to generate all this documentation out of these different systems, some commercial, some not commercial, that could be very challenging. Sure could.
Yeah, I did have somebody ask, specifically what documentation do we see missing from problem list?
Well, the problem list, the only thing that's really required there is your denominator is either all admissions or all unique patients seen during a reportable period of time, and the numerator is, was there something in the problem list? So, they just want to make sure the problem list is being populated with data, or else structured data saying patient has no active problems. So that's really what they're looking for.
I had a question from a client a while ago, and I've not seen someone fail on this topic, but we've addressed and researched the issue around problem list, around is it adequate to be able to capture the problem list, and I think this idea would carry over to some other measures as well as part of post-discharge abstraction.
Sure, certainly.
And the opinion that we came to was it probably is not. Even though your numerator may calculate correctly, an aggressive auditor looking to see will find that that data wasn't available to the clinical staff to be used as part of their ongoing clinical decision making. We see that one is pretty likely to to create a problem.
I would agree with you. I sure would.
Let's see. Let me see. I think we've probably got time to put one more question, and we're running just
Okay.
just a touch.
Fine with me, Jay.
Just a touch over. Oh, and here's one. Client fails an audit in 2011. Their 2012 attestation is still open. Will the failed 2011 audit cause them to lose their 2012 funding?
Not necessarily, but what I've seen as recently as this week is that if somebody is under audit, their next pending incentive is being held based on the prior audit.
Right.
So,
that hadn't been paid yet.
Yeah.
All right. Well, Jim, thanks a lot. That was really terrific. And everybody who asked questions, thanks. If we didn't get to your questions, please, reach out, respond to us a little bit later on at the email on our website, meaningfusemonitor.com, or Jim's site that he mentioned earlier. Before we close out, let me kind of wrap up with sort of a word from our sponsor. I've started watching, Netflix instead of cable or regular TV because I don't like commercials, and here I'm having to give one. But one of the things that we've done is we really, really appreciate everybody being here today. And, we're so very happy that you've attended, that we're going to offer for anybody who's interested in our Meeting for Use Monitor, learning a little bit more, at a very deep discount, a 40% discount to anybody who attends this session and actually registers after the session to indicate their interest on Meeting for Use Monitor later on. So you'll get an email from us. Watch for that email. And other than that, thank you very much, Jim. Thanks everyone else.
Great to be here. Let's do it again in a few months because I'm sure things will have some more information by then as things change, Jay.
I think we'll have an awful lot to go through. All right. Thanks everybody. And
thank you.
So long. Have a terrific day.
Okay. Bye-bye, Jay.